equipment, presence of an IV access, minimal monitoring standards, and all aseptic precautions. The back is cleaned with betadine solution followed by 70% alcohol. 0.5% chlorhexidine solution can also be used as an alternative. Patient is given sitting position with feet resting on the stool and a pillow on the lap. Iliac crests are bilaterally palpated and the intercrystal line corresponds to L45 interspace. An assistant maintains the patient in position by flexing the patient's neck and arms over the pillows, relaxing the shoulders and asking the patient to push out the lower back to open the lumbar spaces. We chose sitting position as it is easy to identify the midline. Spinal anesthesia can also be given in lateral position, which is more comfortable for patient and allows sedation. However, patient must be awake to recognize the sign of pain or paresthesia if needle is in close proximity to the nervous tissue. 2 to 3 ml of 2% lignocaine for local anesthesia is administered in the midline in the chosen space using a 25 gauge needle. We leave the local anesthesia needle in the space as a marker for spinal needle. Back is then covered with sterile drapes, preferably one with a pre-existing circular cutout. Through the midline approach, we access the subarachnoid space between spinous processes, and in paramedian approach, we access the subarachnoid space through interlaminar space. We are using a 25 gauge Vitacare spinal needle with an 18 gauge introducer. The introducer needle is inserted at a slight Keflet angle of about 10 to 15 degrees through skin, subcutaneous tissue, supraspinous ligament up to the interspinous ligament. Introducer needle is stabilized with one hand, and with the other hand the spinal needle is introduced with bevel parallel to the midline. Spinal needle is advanced gradually till change in resistance is noted as a pop sensation as needle passes to the ligamentum flava and dura. Stellate is then removed and CSF appears at the hub. We now stabilize the spinal needle against the patient's back, attach the syringe containing the therapeutic local anesthetic dose to the needle hub and check for free aspiration of CSF. Drug is then injected at a rate of 0.2 ml per second. Before complete injection of the drug, CSF is again aspirated to confirm intrathecal delivery of the drug. Once the drug is injected, the entire assembly of needle and syringe is withdrawn out as one unit. A timer is started to document the start of spinal time. A small, sterile, padded dressing is applied at the back. The patient is then made to lie down flat to assess the extent and quality of sensory and motor block along with monitoring of the vital parameters.